Oh, yeah. The laser, yeah.
Yep.
2000. Go back.
Perfect. Thank you.
Pessoal, hoje temos um prazer enorme em apresentar o professor Zoltán. O professor Zoltán, ele é nefrologista, ele é o chefe da Head da Biomarker Laboratory from Australia, laboratório de biomarcadores da Austrália. E ele tem toda uma linha de pesquisa em biomarcadores e lesão renal aguda. Então, é um baita prazer tê-lo aqui conosco, para poder falar sobre esse tema. It's a pleasure to have you here, us here. Some more residents will come during the class, but don't bother, you just continue. Okay.
Thank you.
Thank you very much for coming here to Brazil for us, and of course for the too.
Thank you. Thank you for the kind words, and it's an honor to be here and be able to come here. And as you know, I'm lucky enough to have a Brazilian working with me, Camila Rodriguez, who's been working with me now for a few years. And unfortunately, I think she's going to come back here, but it would be nicer if she stayed with us. It's been a pleasure to have her. And so that's why I'm here actually in this hospital, and I'm more familiar with this than I otherwise would be. So it's my pleasure to be here. I'm going to talk a little bit about facts, a little bit about philosophy, and maybe hopefully make you think a little bit about what you're doing. These are my disclosures, and this is kind of the problem. Something's not right. The air is clean, the water's pure, we get exercise, everything is organic that we eat and free range, and nobody lives after 30. Yeah? So our problem is similar. All our clinical trials fail in AKI. And I actually think they will continue to fail because of a couple of reasons. But you will see that unfold in the course of my lecture, I hope, and feel free to ask lots of questions at the end and disagree with me. I want to give you an example of why our biomarkers are wrong. This is the molecular transcript of two different injury models in rats. This is this is a volume depletion and an ischemic injury model. I'm not sure if the laser is working. Doesn't matter. Oh, here it is. Yeah. So here's a volume depletion model. Here's an ischemic injury model, and these are molecular transcripts from different parts of the kidney in the same model. These models had the same increase in creatinine, but one of them was caused by volume depletion and the other was caused by ischemia. And you can see these are completely different, right? There's no relationship between them. And yet the usual treatment in the ICU and the general wards is the same. You give them all volume and then you hope for the best and start praying, right? So actually we're not treating at all. We are rescuing people with AKI, and that will unfold as we go along. And part of the problem is our terminology, and I'll mention that a bit more, but part of it is also the way we think about AKI. So one of the problems, and there are many ways to put this, but AKI trials have all failed. The pathophysiology of the kidney is complex. This is the master organ in the body. The brain is secondary to the kidney. The heart is just a pump. And the kidney is very complex and it's very sensitive, and the feelings get hurt very quickly. It's very heterogeneous. There are lots of cells, lots of functions, lots of things going on. Nobody here can tell me what starts glomerular filtration, what stops glomerular filtration in AKI. And we don't know that after more than 100 years of thinking about it. So we're not doing very well in what we understand about the kidney at the moment. And there are other problems as well that are simpler to think about, but the translation of experimental AKI into successful trials has been a failure because of the definition of AKI, because of delay, because poor understanding of human AKI especially. Nobody biopsies people when they AKI starts we don't know anything about AKI in humans at the start, and later in KI this year there will be a controversies debate, and I'll be proposing that we do biopsies in AKI early on. The animal models are not necessarily the same as human models. The molecular targets are usually unknown, and it's a bit of a blunderbuss. It's a bit like steroids. We don't know what we're doing, but it seems to work. And the biggest problem, I think, probably is heterogeneity in the case mix, in the phenotype, and we're probably targeting the wrong population every time. So, and I don't think we've defined the question properly, but I'll come back to that at the end if there's time. The good thing from a nephrological perspective is that we're not unique. The same problem exists in cancer. If you look at cancer treatment using one particular type of agent, in 2008, this particular agent was used for breast cancer mutations that are BRCA2 positive. And then it was discovered that this same drug could be used in ovarian cancer, but it took nearly 14 or 8 years to become authorized to use in ovarian cancer. And then it took another 4 years before it was used in additional cancer therapies. In this space of time, the same molecular pattern of cancer, which is susceptible to the same treatment, probably 1 million people at least have died of these various cancers while it was being approved for use in these different models. And the reason here is the names that we're using, and naming here was based on the site of origin. Breast cancer is not the same as ovarian cancer, kidney cancer, etc. So the problem is in the naming and how we think about AKI as well as in the type of cancer. So what I'm going to suggest is that we change the way we think about AKI in the way we name it, as well as a more general sense. So precision medicine is targeting treatment to the disease. And to do that, you need some precision. And we don't have any precision in AKI, right? We need to identify the cause of AKI. We need to identify the mechanism in different stages of AKI, because different stages will have different treatments. I call that the phase of injury, and you can call it severity, but they're actually different. The severity is an arbitrary classification based on a functional analysis. And just to sort of get on my hobby horse, we don't diagnose myocardial infarction using an echocardiogram to detect cardiac failure. But in kidney injury, we use function to diagnose acute kidney injury. So of course it's late and it's probably irrelevant by the time it happens. And the only reason we measure creatinine and the only reason that you're told what to do with it is because you think, when should I start dialysis? Not how should I treat the disease? So our thinking is faulty. So how do we go? Well, I think we should rename AKI. There have been many names for AKI. There have been different trends, and as the names change, you know, people get confused, there's loss of interest. And in fact, in my country, Camilla was at least fascinated that in my department, there are 2 nephrologists interested in AKI. The other 6 do other things, and they're pet hobbies. And in Australia for 30 years, I was the only nephrologist who was interested in AKI, because the intensivists thought they were running it all and doing what they wanted anyway, although the majority of cases of AKI actually occur outside the ICU. But you guys deal with the end of the road patients who are about to die, and so that's important. I'm going to tell you that it's probably the wrong end of the stick. And there's a problem in translating names as well. Not all names are easy. You know, to have a funny name doesn't necessarily tell you, but it may be just the right name for designing a treatment. So most of what I'm going to talk about is in these two papers that I wrote with Camilla and that have been published in the last year or so. We'll start with the naming as a phenotype. AKI is a syndrome, and we're going to start using these terms, and you'll hear about subphenotypes all the time. And I'm not sure what the right way to do this is, but we decided when we wrote not the first paper, but the second paper in intensive care medicine, this bottom one, is that we will use the following classification, that the phenotype is the syndrome. The next layer is the subphenotype, that includes cause. The next layer is an endophenotype, or endotype for short. And then under that, if it's treatable and the mechanism is the same and it works, we'll call it a treatable trait. But, you know, this is like medical jargon. We have a language to make sure everybody else does not understand and that we understand. So that's how some of this works. So we've had classifications, and they're all creatinine-based definitions, and that's really probably the main problem that's wrong with them. We've slightly advanced, I think, by using the matrix definition of AKI, where you now have injury biomarkers available and function. This could be cystatin C, it could be proenkephalin, it could be creatinine, and we have biomarker negative and no AKI, over here biomarker positive, and also functional change. Here we've got functional change without a biomarker change, and here we've got a biomarker positive change without a functional change. And these are all valid. This is actually subclinical AKI, and it has the same outcome as this, which is biomarker negative, even though the causes are different. So the fact that the creatinine goes up or the biomarkers become positive is important. Which of those is more important depends on what you want to treat. And that becomes the issue then. And, you know, biomarkers, if they're present, predict reduced survival. This is just one example in sepsis, AKI. But, you know, if you're biomarker positive, you're going to do worse, right? So it's valid to think of biomarkers as an add-on or as a substitute for creatinine. And this is where, if you have the tests available, that you will be able to, I think, triage patients in a different way in the future than we have been in the past in relation to kidney function. So a phenotype is a set of features now in common with a syndrome. ARDS is an example. Hepatorenal syndrome is an example. AKI is where you've got functional changes plus or minus a biomarker change. A subphenotype is, they've got the same phenotype, but now it might be a different cause. It might be a different prognosis. It might be a different risk factor for disease, right? So we've now got different categories. And you know from your experience in the ICU that the outcomes are different with all of those. So this is the problem, that we're lumping them all together in treatment instead of separating them. And clinical trials want to have numbers, so everyone is lumped together, and of course the trials are negative. Endotypes are a subset of the same subphenotype. That should be a subphenotype in there. I'm sorry, this is a sub here, that have the same mechanism. Is it hypoxia? Is it mitochondrial injury? Is it construction? All of these things are reasonable as subphenotypes or endotypes. And then if we can treat it one characteristic and it works consistently, then we'll end up calling it a treatable trait. So you can use biomarkers for different things. You can use them to reduce that heterogeneity, and that allows you, let's say, to say the same people who are going to die or need dialysis or going to have cardiac failure in this scenario, then you can actually subphenotype these and now bring them together for a trial. Alternatively, you can look at common biology in the group as a different biomarker that says, okay, these all have mitochondrial energy, yet let's use an agent that will treat the mitochondria. And so this is, I think, the way that a lot of trials will eventually run in the future. But of course, it makes it a little bit harder. So to give you the indication, here's your phenotype with the matrix definition of AKI. And then you have all these people with subphenotypes, either by cause or by biomarkers, and you can then get a different endotype from each of these, and maybe one of these will be treatable in a consistent framework. So these are different endotypes, and I'm going to talk about some of these now to just give you examples of how this can be used and might have some validity in the future. So from biomarkers themselves or the context of injury, the same prognosis, etc. And the terms, I think, are important. I hate the term pre-renal, because the automatic reflex associated with the word pre-renal in my fellow's eyes is to put up the saline. You know, now we can put up Hartmann's or Plasmolite or something else as well, but it's a reflex. You know, we don't want that reflex, because if you look, and I'll tell you in a minute, show you my classification that Camilla and I put together. Most of the causes that we lump as pre-renal do worse with fluid than without. So you don't want to just put fluid up. So that's the problem. And the second bit of the terminology, so we need to define the cause, the subphenotype, for example, and use that in our thinking, because that then allows correct management. The second thing is that diagnosis and prediction are used very commonly and somewhat interchangeably. They don't mean the same thing. If a biomarker is positive, it's not because it thought it was a good idea, it's because something has happened. And so in that scenario, an event has already occurred. So if we diagnose AKI with a biomarker, there is damage, right? No question. It may be stress, it may be fragmentation, it may be some other form of damage, but something has happened. It hasn't just gone up because it feels like it. And so prediction versus diagnosis sometimes are confused, and the syndrome names are very helpful, like KDIGO definition of AKI, because we then say, well, the outcome from Facultas Clinicas results in AKI are the same as they are at Prince of Wales in Sydney. You know, these are very good hospitals, because stage 1 has the same outcome in each hospital. But does it mean that we've actually handled it the right way? No, not necessarily the same idea at all, but it allows some epidemiology to be done that's satisfactory. So I think you need to think a little bit about the naming of things and how we use the terms. We can divide biomarkers, if you like, into creating biological subphenotypes and then look at clinical subphenotypes. But either way, I think they're useful, and I don't think I'll stay on that. But there are different naming terminologies now for using these biomarkers, either as a diagnosis or the subphenotyping with cause, biology, prognosis, prediction, pharmacodynamic, monitoring the levels of a biomarker might tell you whether your treatment is working. These are all potential uses of biomarkers, and they may be used in the same scenario for different purposes. So, for example, you might have patients with acute tubular injury, and that's a better term than acute tubular necrosis, but they're still problematic, if you like. And we can have diagnostic biomarkers and say, well, this is not ATI, it's not ATN, so we're not going to look at those patients in this study. But if they are prognostic and they are ATI, then now we can put them into high and low risk categories, and this might help us triage patients to enroll in a clinical trial. And the example of that, for instance, in NephroCheck, and I'll come back to that later, after cardiac surgery has been used to triage patients into treatment groups. And you're going to see Alex Zarbok in Münster, where they did the Pravaki study and showed that you could actually now randomize people to careful monitoring hemodynamic stuff, and they actually did better, had less AKI. So you can use biomarkers in this way. There are many subphenotypes. Some of them are listed here. Cause I'm going to talk about a lot. Risk, mechanism, and some other shared features might be relevant. So there are many causes of AKI, and the way that we've classified them here is, I think, a little bit simpler. And if you think of the word lion, then you'll remember this. And in medicine, we always need to visualize something, and pre-renal, renal, and post-renal was an easy way to visualize it, but you then forgot all the causes of pre-renal. So maybe think of lion and think of low perfusion, and then think of the 3 V's, because if you have 3 V's for vascular, ventricular, and volume, and each of those is a plus or minus, then you've actually got an easy way to remember all of this. The I is actually for inflammatory and immune, and you can include sepsis here. Of course, you can also include sepsis with volume, or you can include sepsis with output and flow, but in fact, the evidence for reduced blood flow with sepsis is much lower than the evidence for increased blood flow with sepsis. So there are different mechanisms involved in some of the conditions here. But this is an alternative classification, which I think might help management rather than just be my hobby horse. And this is the important point. You can't tell any of those from measuring the serum creatinine. So what else can we look at? Well, we could look at trajectories, and this is probably more important than it would seem. If we look at trajectories of creatinine change, then we've got more terminology here. AKI is within 7 days of an event. If it's persistent, it's lasted more than 48 hours. If it's more than 7 days but less than 90, it's acute kidney disease. And if it's longer than 90 days, it's now CKD. Now, this is more important for epidemiology, if you like, than anything else. However, it does have significance. If you look at over 150,000 patients with AKI, and you look at their trajectories based on whether this is persistent AKI, more than 48 hours or not, then you can see that incomplete recovery or persistence actually is associated with mortality. And this is an interesting group from the Florida database of Azra Viharach. And what she showed nicely, I think, in this is that firstly, that if you have no AKI, you do better, of course. If you have AKI that's persistent without recovery, you do very badly. If you recover somewhat, you do better. And if you rapidly recover, you do better still. So these categories have got some meaning in terms of outcome. The other thing that's interesting, actually, though, is to notice is that the outcome is predictable very early. You see this quickly. You know, that's why 30-day mortality is useful. That's why 3-month mortality is useful. You don't have to wait years to see these differences. So there are a couple of risk subphenotypes. One of them is low kidney functional reserve. What's reserve? Well, we don't really know, but we think it's the stuff that makes pregnant women have improved renal function. It allows clearance to improve during pregnancy. And we're doing studies, and Camilla's heavily involved in this, and I'll let her tell you the outcomes in patients prior to cardiac surgery to look at their kidney functional reserve, prior to nephrectomy to predict what their kidney function will be in the future. And some of those things are relevant. Stress, I don't know what stress means, but NephroCheck has now become a stress biomarker instead of a damage biomarker. It was never made in the kidney anyway, so there was a little bit of smoke and mirrors associated with that biomarker, but it's still useful. And I think it might be useful. So here's an example of low kidney functional reserve, and Claudio Ronco's group published this a few years ago, and they looked at 100 patients with normal serum creatinine and found that only those patients developed AKI if they had a kidney function reserve based on creatinine clearance, which was less than 15 mils a minute. Now, I think creatinine clearance is a terrible marker of most things. I've published lots of papers on it, don't worry, and it works, but it works only when there is damage to the kidney. When there's no saturation of tubular secretion, creatinine clearance is poorly related to true measured GFR. And we've published a paper recently in American Journal of Physiology, which shows this very nicely. Tubular secretion and tubular function is probably going to become much more interesting in the future because it is what makes creatinine clearance useful at that time. So we're lucky at the moment. Creatinine going up saturates the tubular receptors for secretion, and then GFR and creatinine clearance are related. If they're not saturated, they're not very related. But anyway, the message here is if you have low reserve, maybe that explains why two people with the same creatinine go in for cardiac surgery, one develops AKI and the other one doesn't. So that's one possible explanation in that scenario. Another example of stress markers and triaging and risk identification is the Prof trial, which I mentioned already, using NephroCheck, this TIMP2 by IGF-BP7 combination. And they used 0.3, and I'd probably use 0.5 now instead of that as a triaging value to randomize patients into standard care or into intervention just with hemodynamic monitoring and removing things. Everyone tells you they do that anyway. Of course you do that in the ICU. But if you don't do it to the same standard in your standard of care, you get a different outcome. And that's what they basically showed, that in fact that you had less AKI overall and definitely less severe AKI if you in fact triage those patients to hemodynamic monitoring and you had a stable hemodynamic function based on SVO2. So endotypes now, there are various endotypes, and I can go at length on this, and I'm struggling to give you a different talk to the one I'm going to give on Thursday, so I'll confine it to some of these. A very interesting endotype is those patients who respond to angiotensin II. And looking at the ATHOS study, which they did, we had previously done some studies on angiotensin II years ago in rats where we showed that angiotensin II restored renal autoregulation and inhibited nitric oxide injury in a perfused kidney model. In the ATHOS trial, they showed some patients responded to angiotensin II and others didn't, but the standard group of patients they were looking at were patients with vasodilatory shock who weren't responsive now to norepinephrine and so on, ADH and so on. They weren't actually responding, and then they randomized them into this trial. Now, this group was interesting, and they looked at them retrospectively, and they found that they divided into a low renin group and a high renin group, and those patients with low renin had no difference in their response to angiotensin II. Those patients with high renin divided into those patients who responded now to angiotensin II infusion. And it looks like that your baseline serum renin is proportional to the ratio of angiotensin I and angiotensin II. And you know they transform, and patients therefore who have low renin don't have any difference, but the patients with high renin clearly are not able to transform, and therefore renin is not suppressed by high Ang2 levels. And so this seemed to be the defining feature in this trial. And that suggests then that high renin in sepsis AKI associated with circulatory collapse could be a treatable trait because they look like that group now and not being able to generate aldosterone, and they will now respond to angiotensin II, whereas the others don't. So it's an interesting way to think about it, but now it allows you to create a homogeneous group that you can subject to a clinical trial and treat. Let's look at heart failure, acute decompensated heart failure. We know that patients with heart failure respond to decongestion. If you don't respond to decongestion, you die, right? So this is the group that do better. But the problem is a lot of the patients with heart failure, the cardiologist rings up and says, creatinine's gone up, okay, I will have to slow down the diuretics. And that's the wrong message, right? You want to let the creatinine go up, those patients will do better. And worsening renal function in that group actually predicts better outcomes. And I think it suggests that creatinine, a useless biomarker that it is actually telling you something about volume status in these patients, not about kidney function. And so it's helpful in this scenario, and I don't think you should stop your diuretics. And in fact, if you look at biomarkers of damage in the urine or in the plasma of these patients, there's no relationship to that level of outcome. So in fact, it looks like patients whose creatinine goes up in heart failure, decongest them properly, that's a good sign. There is an anomalous outcome in that same study that suggested that the ones with the highest biomarkers actually did better. And the funny thing about that is that we previously showed in animal models that biomarker output seems to correlate with viable nephron mass. So if you have better kidneys, you'll have higher biomarker levels. If you have poorer kidney function in the first place, you'll do worse. So the background disease actually transforms this. And one of your problems is that most of our patients are not normal. They don't come along, and the creatinine might be normal, but actually they've had diabetes for 30 years, and actually the 50% of the kidney is already sclerosed, and you don't know that, but the creatinine looks normal. And so a lot of our patients have got comorbidities that have affected the kidneys, and the creatinine is not a good biomarker for telling you that. So viable nephron mass may be an important marker. How can we identify some of these subphenotypes? Well, another way is machine learning. It's very trendy now to talk about AI in every way that you'd like to think about it. And you'll all be using AI to find your lunch after this, because it'll tell you what the demographics of the rooms are. So, but you have to input a lot of data. And this is an example of a sepsis study where they retrospectively analyzed a lot of biomarkers, demographic biomarkers now in these patients. They used statistical analysis now to find separate associations, and they defined 4 basic groups with this strategy. 4 basic, they call them phenotypes, but they're really subphenotypes in this category. And these are the different trials, and they each seem to have a consistent set of subphenotypes, and some of these are more to do with inflammation, others and different forms of injury, and each of the different trials had a different looking pattern. When they looked at retrospectively at these biomarkers and looked at damage biomarkers in that same scenario, and also at the treatments that were given, it would appear that the treatment categories, for instance, if you look at activated protein C, is more likely to work in one of these subphenotypes than the others. And so maybe machine learning will help designate some of these subphenotypes. They've done the same thing in children and found that these variables will allow you to look at that. The problem with this is that, to be any use clinically, you need to know what the result is immediately. This is the patient coming in, all the machines have to feed together, you have to have the results straight away, and you say, well, this is patient number 1, fits into this category, that's fine, we'll do this form of treatment. Now, you do that computation every time you see a patient. You already do that at the end of the bed, but you just don't use fancy terminology to describe the subphenotype. But you have a good sense of whether someone's going to live or die, whether they've got AKI, whether they're going to actually develop a toxic shock, a whole range of things. And this is a way of trying to bring those things into a more systematic process, I guess. But it has potential, I think. I think it's actually hard work, and you need a lot of data to validate all of these things. And again, it's even worse than standard damage biomarkers, that most hospitals won't be able to do this for a very long time. But I think it actually highlights heterogeneity. It tells you that when you look at any one population, there are a lot of things going on out there that mostly we're not taking into account. Let me give you another example, a more positive one. Urine TNF alpha and IL-9, interleukin 9, appear to predict acute interstitial nephritis. Now, if you do a biopsy in patients with AKI, this is the most common finding is acute interstitial nephritis. It may be drug-induced. And what's more, if they initially showed that one of these, IL-9, was actually predictive of response to prednisone therapy. So this could almost be a treatable trait. The same group went on and showed not only that IL-9 was useful, they did another study which then showed that CXCL9 in a proteomic study was even better at predicting acute interstitial nephritis. And so it seems that this will be a highly discriminatory biomarker, and we all want one biomarker to tell us what to do. It's actually a fantasy, but nevertheless, we'd like that, because as doctors, we're very dichotomous. We want a black or white answer to everything. It doesn't work like that, unfortunately. But CXCL9 is a nice biomarker that works. And there are a bunch of biomarkers that seem to have value. Urinary NGAL in hepatorenal syndrome probably is a good biomarker, telling you whether you should use octreotide. I'm trying to think of the other, terlipressin. And if urinary NGAL is high, you shouldn't use terlipressin, it's too late. So it's a rule-out biomarker. Nephrocheck is probably helpful post-cardiac surgery, and urine NGAL is clearly useful in children and now been licensed by the FDA in pediatric ICUs and so on for that use. And in fact, I visited Cincinnati 2 years ago, and I was impressed that every shift the residents in the ICU would measure NGAL for those patients on dialysis, and they would predict whether that patient would need dialysis in the next shift or not, or whether they could come off dialysis, or whether they didn't even need now to have their perm cath put in. So they're very useful things. So there are a bunch of biomarkers that are useful. The IL-9 I've mentioned, and CXCL9. With the kidney donors, there are some biomarkers that may be useful, but they haven't really had much validation. After AKI, some of these biomarkers seem to predict outcome very well. And there are categories then that we can look at, like cirrhosis, critically ill children, AIN, drug safety monitoring, kidney donors, and after AKI, where biomarkers are clearly helpful in predicting outcomes. So these are the things that biomarkers will do. They'll help define risk of AKI. They may define subphenotypes and endotypes and help you with your trial enrichment. And almost everything I've said is summarized here. And if you take risk, diagnosis, subphenotype, endotype, and then treatable trait, you go from risk, and we know high risk, for example, CKD is high risk, the single most high risk for AKI after surgery. DICOP3 is a biomarker in urine which appears to predict that too. Kidney functional reserve might be useful. And after an exposure, then NephroCheck seems to be useful in predicting worse outcomes. In diagnosis, you've got your standard biomarkers like urine output, creatinine, and so on. But in the first 48 hours after cardiac surgery, the patients are so dilute that creatinine is useless. So you're not able to diagnose AKI until 72 hours later with any confidence. But urinary biomarkers like NGAL and KIM1 and TIM2 and in Japan, liver fatty acid binding protein are useful in that scenario. Subphenotypes, always think of cause. I think line is a useful term. I'll put it to you, and since Camilla's now got a name on the paper, you have to use it in Brazil. It's essential now. And I think prognosis, mechanism, and other biomarkers in the urine sediment, as well as other things, are established as helping us make specific diagnosis. You know, ANCA is high, this is ANCA-specific glomerulonephritis. We know how to treat that. There is a way of targeting that. If the ANCA is not high, you don't use the same drugs in this form of vasculitis or that form of vasculitis. So we need to actually be very specific in what we're doing with our treatments in order to do that, and you have to be specific in your diagnosis. It's no use saying they've got AKI. I might as well say, so what? I've seen it before, right? That's about as much use as it is to say that. Okay, and then endotypes, we've got a bunch of treatable traits. Sometimes the biomarkers will be helpful in excluding types of treatment, like terlipressin. If somebody's urinary NGAL is high, it's not going to be much use. It's too late. And in heart failure, which is pretty common and deadly, the biomarkers in the urine would be helpful if they're very high. But if you haven't got them available, then you're stuck with creatinine, and my recommendation is to let the creatinine go up. So, and then finally, treatable traits. We've mentioned a few things like renin, high renin, and IL-9 as being very useful markers in that scenario. So in summary, AKI is a syndrome. The management that you're conducting on this every day is rescue, it's not treatment, because you're not treating the disease. What you treat that caused the AKI, that may be relevant. But for years, people used to say that people don't die of kidney failure. They die of all the other things. I think that's rubbish, right? It's easier to say they died of a heart attack, but the tenfold increase in cardiac risk associated with the AKI and the CKD was not there by accident. So people do die of kidney failure and kidney injury, and the inter-organ cytokines and interleukins, etc., that actually are now sending signals to these other organs. There is remote organ injury, so that is a problem. I think the language we use is very important. You need to identify the syndrome and identify carefully the language that you use to do that. Biomarkers can assist. Most of the trials that you're doing will fail. And I think that's probably because we're focused on the wrong target population with AKI. But I don't think I should dwell on that today because it's going to take too long. So greetings from Sydney. That's Camilla in the middle there. If you, unfortunately, she's coming back to you, but I regret that. But thank you for your attention. I'm happy to take any questions.
Professor, I have a doubt, Professor. When I think about strategy, I think it's interesting strategy, such as a panel of biomarkers, different kind of biomarkers, such as NephroCheck or plus NGAL. I think it's affordable. It's interesting in AKI.
Absolutely, I think it is. I think, you know, sometimes I show a slide showing how biomarkers in cardiology have advanced treatment of myocardial infarction and ischemic injury. And In the 50s, you had SGPT, SGOT, and then you had LDH, and then after that you had CK, and then you had CKMB, and then you had troponin, and then you had different troponins, right? And there are other biomarkers of acute myocardial injury, and you've seen the decrease in time with myocardial infarction in the community. Everywhere in the world, treatment has improved outcomes from myocardial infarction. At the same time, in nephrology, our biomarker of kidney function has gone from creatinine to creatinine to creatinine to creatinine to creatinine. Okay, so what we need are biomarkers, and the cardiologists know how to use these biomarkers better than we do, and they still do trials and work out, well, should you do these serially? Should you repeat your troponin 2 hours or 4 hours later before you discharge someone from the ED? Or should you actually wait longer, and what's the right thing to do? But you've at least got some insight into what to do. We need to do the same thing with biomarkers for kidney damage, kidney stress, and I think a panel is essential. Each biomarker has a different time course. So injury here, this one rises quickly, disappears. As if you look at urinary gamma GT and alkaline phosphatase, which I did years ago, goes up, goes down, because it's sitting in the brush border of proximal tubular cells. It sloughs into the urine, it goes up, and then it comes out. Okay, great. That's an early biomarker. You look at later ones, KIM1, NGAL, and even later ones, and that gives you some idea of two things. One is the time course, and the other is it tells you that something bad has happened, and you can rule in or rule out those patients, but also triage them in the ICU, for instance. There are some patients you worry about and some patients you don't worry about. Now, one day in the ICU, I don't know about Brazil, but in Australia, one day in the ICU costs at least $10,000, right? One day in the general ward costs $2,000 or so. So if you can move someone out of the ICU into the general ward, you've saved $8,000. The panel for 3 biomarkers is going to cost you, I don't know, $100. Is it worth it? Go figure. Of course it's worth it. And the problem, I think, is everything has got tighter, and finance is important. I'm not saying that we should ignore that, but over the years, the cardiologists have had a lot of fun. Nobody's checked their finances. And unlike us, they don't send patients with a little bit of angina away. They actually investigate them. Nephrologists and intensivists don't care about stage 1 AKI. It's not important, you know. It's the only place it'll make a difference. All of the stage 3 AKIs, you're dealing with rescue, right? Why is the outcome bad? Because these people are nearly dead. Their kidneys are nearly dead. And you want to rescue them. Well, great, keep them alive and the kidney will rescue itself, maybe. But you're not dealing with a mechanism, you're not dealing with a disease process, you're dealing with life support. It's the same as ARDS, right? You're putting people on ECMO. You're actually doing stuff that keeps people alive and you're hoping that they get better. It's not because of your magic, unfortunately, it's because you're keeping them alive, all right? And then maybe all the trials that have been used, some of those could be redone properly if we had a homogeneous group each time. But unfortunately, unless we use biomarkers, we'll never have homogeneous groups.
Thinking about the money we use to explain, if you had to choose one, what is the biomarker you would to choose? And government to check, and the trial for Aki did show the association with the reduction of dialysis. What do you think about?
Two things. One, to declare my conflict of interest. NGAL people gave me a shirt that said NCAL champion, so I just want to let you know that. It's another disclosure, but I would use NGAL. It's got the most studies. It's actually pretty reliable, but it doesn't always work, right? If I was in Japan and I could get it cheaply, I'd use L-fatty acid binder protein, which now is actually routine in Japan in a whole bunch of scenarios. So I would use one of those two if I could only get one biomarker. I would prefer to get a panel of biomarkers, and I would prefer, if I had all my choices, I would use KIM-1. In my lab, KIM-1 is the best of all of them. And the problem is that in 2003, I think, when Joe Bonventri's group published all that stuff, Abbott took away, wanted to license KIM-1 and so on, and gave it back. I'm not sure if it's because the antibodies to KIM-1 were not reliable. KIM-1 is a transmembrane protein that goes from the cytosol into the lumen of the nephron, and different sections of it occur in AKI. And I think there was some doubt about whether or not this could be reliably standardized. But in all of the tests that they have done where they've used histological criteria as the classifier, as the outcome, KIM-1 has beaten all the other biomarkers. And in my lab, KIM-1 is the most reliable of all the biomarkers. So I'm not sure, but it's not available as a routine test. So NGAL, L-fatty acid binder protein, I think they're the two best at the moment. I think NephroCheck does have some uses, but it's not quite as good as it seemed to be when it first came out. Of course, everything is like that. The more heterogeneous the sample, the less reliable any biomarker is. And there's a great paper by Sus Waikar about almost 10 years ago now, where he showed that if you had a biomarker that was 100% sensitive and 100% specific, and you use a biomarker to decide whether that is now valid or not, but the validation is with a biomarker that is only 80% specific and 80% sensitive, then the best sensitivity you can achieve with the biomarker that is 100% effective is 54%. So all of our trials of biomarkers are ruined by heterogeneity and by the fact that they're all validated against creatinine, which has only got 80% sensitivity and specificity. So you've got a real problem in looking at these things. And I think we have to go past the mental block that says, I want an AUC of 0.95, otherwise I'm not going to buy that biomarker, right? You're never going to understand how to use AKI biomarkers if we have to have an AUC of 0.95, because the way we're validating it is wrong. And so it's never going to get there. So it's going to save money, but it's not actually going to help us with disease. And I think we think about AKI the wrong way. And I mean, I think we're looking at the bottom of the cliff, not at the top of the cliff.
Thinking about technology and panels of biomarkers, there is a bit of complexity to political decisions of everything else. And thinking about all the heterogeneity, do you think the average clinical doctor will be able to make decisions based on panel of biomarkers, or are we going to need some kind of software to maybe help us filter the signal from the noise and identify the critical traits, and then so we can actually concentrate on what matters?
It's a nice question. I guess I have two answers. One is, I think most doctors are not stupid. Some, but so you can answer the question in one way yourself by saying, well, can the average doctor use troponin properly? Okay, so But troponin has evolved over 50 years of playing with cardiac biomarkers. And I would suggest that you would not know how to read an ECG if you didn't do it regularly. And that's the potassium lives in the T wave and the QRS is wide and it does this. If you're not doing that all the time, then you're not going to diagnose torsade de pointe, right? You're not going to actually look at first, second degree, third degree heart block and say, this is how it works, right? The average intern comes out, they don't know about first degree heart block. They learned about that in medical school, didn't they? Right? They learned about second degree heart block, but they're not sure what it is. And the registrar or the fellow has to tell them a couple of times, and then they go, oh, maybe that's what it is. And 3 years later, they know a little bit about it. Okay, so I don't think biomarkers are different to that. I think we are bad at understanding what kidneys do. And I think because of the amount of medicine that we have to know, that physiology, systems physiology has diminished. And unfortunately, our understanding of how things interact has diminished. And you've got all these facts in your head and you know which biomarker, oh, I have to measure a KIM1 today. And that tells me that, So you can use software, and I think AI will help in that, but even simpler things will help. I mean, I think calculating an EGFR from a creatinine has helped. It's not been perfect, and there's a lot of fluctuation in both because they're related, and when you have a steak and you eat a Brazilian diet, your creatinine is going to be high, and if you're a vegetarian, it's going to be lower, and that makes no difference to your kidney function. Okay, so, translating those things takes a while, okay? But I think that we can do that, and we have to actually slowly do it. Otherwise, it's when I introduced computers into medicine in medical school in 93, and in Queensland when I was working there. And the professors would get up and they say, you don't need computers to do medicine. How many of you don't use computers? Put your hand up, right? So, you've got to evolve. We have to take these things into account and progress and use these things. And I think these biomarkers are easy compared to working out how to run a ventilator, right? You managed to do that. Look at that.
Very much for sharing your knowledge with us. I strongly agree with the philosophical question that there's no one silver bullet to diagnose or tell you everything that you need for manage the favor. But how do you think that kidney biopsy could help separate or give you this information that?
Well, just to give the game away a little bit, I will be advocating for biopsies in acute kidney injury. I have some caveats in that. Firstly, we don't know anything about human AKI in the first 48 hours. Zip, nada, right? And I think biopsy will help. But what we do know about biopsies that have been done in AKI is that injury is focal. The injury is not sheet-like necrosis of proximal tubular cells, which I've created many times in rat models. It's very targeted to brush border initially. It's to the outer stripe of the outer medulla, and that'll be different in human kidneys than it is in rats. And so there's a lot that we don't know that we have assumed from our rat models, and biopsy will help a little bit. But the problem with biopsy at the moment, I think, is that it's also medieval, right? To be generous. Now, I topped pathology when I went to medical school. Am I a pathologist? No. But I can tell you that biopsy evaluation hasn't changed much since I went to medical school, right? And here am I telling you about biomarkers of damage. And if we talked about mechanisms, I'll tell you about mitochondrial injury and opening of the mitochondrial core, that KIM1 is actually now, expression is upregulated. This happens, that happens. Do we measure any of that in the biopsy? No. Could we? Yes. So I think what we need to do is to upskill pathology from being like dermatology at the moment. And I don't want to offend any of my pathology friends because I love them dearly. But it's very descriptive. And when I was at medical school, actually pathology was the best experimental group that there was. These were the best guys. They were the ones who were changing things and seeing what happened in the slide, right? Now, it hasn't changed much for a long time. We need to upskill, and there is a project at NIH, which you may be aware of, which is a precision management medicine tool where they're doing biopsies in selected units, contributing samples, but it's not a global thing. It has the usual problems with American medicine and being very strategized and very localized, but it's well-intentioned. So I'm not trying to criticize it. We need that evidence, and we need to upskill how we interpret the biopsies as well. If you do a biopsy and you stain for NGAL or KIM1, you'll see stuff that you don't see when you look under hematoxylin and eosin, right? You won't see the changes that are actually dynamic unless you actually stain for them.
Talking to my friends from the pathology department, that patient, oh, there's no difference. They're the same. Must be something wrong.
Yeah, the way we interpret the biopsies is a real problem. And having done a lot of experimental pathology, there are subtle changes that are viewed as either artifacts in human biopsies, or they're overinterpreted. There's crinkling of the capillary membrane because of the hypotension and the underperfusion. Therefore, this is actually must be acute tubular injury, and that's consistent with that. Yeah, it might be, but if you didn't tell the pathologist what the condition was that you were looking for, they wouldn't actually make that pathological diagnosis. So I have a problem with the objectivity in some of the analyses, and I have a problem with the lack of modernization of the investigations. Look, in transplant biopsies, we've gone a long way because we're staining for lymphocytes, we're staining for CD4, we've got lots of different markers that we can look at that help us say, well, you've got that many lymphocytes in the endothelium, this is vascular, its prognosis is bad, or it's only in the tubules, prognosis is a little bit better, but also helps guide treatment. Is this acute antibody-mediated rejection, or is it T-cell mediated rejection? You're starting to categorize that. There is no reason we can't do the same thing with AKI.
Thank you very much. We would like to have you one more time, but it's time already. And we're very thankful for your presence here today.
Thank you.
Yeah. Oh, yeah.
Okay.